Como se había dicho en el primero que por ejemplo, se tira como una batería. Porque por ejemplo, cuando se switch que aprende el dash, la primera pero así que. ¿Qué dices?
¿Y cuánto es eso?
41. Sí, te decía la caja de yo puse esta cuando yo pero se han dado como que se los vieron. Bueno, me parece que me paso. Todavía a los cupones sí, pero otro no. Pero yo creo que cuando Shelly, cuando llegamos a la de Daddy que sí. Sí, yo puse, ahora vamos a poner una aproximado puse de la primera. Yo le digo que no puse de faltar comercial, no tenemos.
Is this usually what's currently going
Sí. Yo creo que lo sé.
I've seen all of it.
I just never really watched it.
Yeah. Oh, that's the one. We're watching a certain part of Dragon Ball Z. We're watching that here, but I'm on the current episodes on that.
Sí, bueno, me parece bien.
Yeah, I'm watching it. Yeah.
Pero aparte se me
I don't think they've took out the filler, but they put it in a more concise way. Where it's easier to find like the actual things you need.
Que ellos no quieren hacer ahora porque no quiero pasar yo
cuando lo llenen no trabajamos.
Yo creo que te lleva un email.
Sí. Yo había puesto un aproximado de lo que compraba y la hora que trabajaba. Quiero abrir una pregunta.
Yeah, it comes out everything.
La hora.
No, it's
Un documento
Oh,
de la farmacia.
yeah,
Como que lo que yo cobro. Usted no es de la farmacia.
no, what else? What other shows?
What was
Casi oculta.
No. voy a decir algo. Pues 3 días de que esperar ese pago médico.
No es nada. Como yo no puedo hacer
Oh wow, they have a countdown.
website.
Yeah, yeah, and it's the only, if you're watching it on TV, it's the only one that
Ahí me había, si yo había subido su statement de pago.
stuff.
Ajá, exacto, como que el 24, pero
Yo lo hice.
yo hice un banco.
Is there a competition?
No, claro que voy a ir
¿Para qué te están pidiendo?
La verdad,
If you like get hit by those
yeah.
you're gonna get pancake.
You wanna see something really cool?
Pero eso cuando hagan revisión, entonces lo hacen. Pues me había enviado revisión de eso.
Yeah. What?
Que yo puse, yo no sé qué pasó, se me descontó
No,
975 y me costaron 100 pesos.
He has a podcast.
Oh my god.
Aquí se me descontó.
Medicaid sigue igual. Pero no sé, no se me descontó. Pero sí me acuerdo que para una sonda yo puse statement de los bancos y lo del trabajo, cuánto cobraba.
Like it's
Eso es verdad, se le dice todo el tiempo de
Yeah,
nada.
more than
Sí, 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 pensaba.
That's the reason when it gets heavy.
wow.
For 34.
Mira, esto que te
Damn those guys.
Yeah.
Yeah, yeah.
It's really nice.
Especially during this one.
Yeah, because there's more instructions.
It's too much.
It's too much. It's too much.
Chiquitita. ¿Cómo se dice chiquitita en inglés?
Chiquitita little.
Chiquitita. Yeah. It is a sound.
No,
pero es que
I'm not sorry, but
it is a sound. Yeah.
Chiquitita, okay, when we would eat that, it's like really
Or ito.
or it's like more than Ita is like, for example, when they call me Ernestito because my father is
Little.
Okay, guys, it's 2:30. Happy Friday. Class was supposed to start at 1:30 today per the schedule that you all have. So I apologize for the confusion. I have updated the course syllabus. So before it was saying Monday, Wednesday, Friday, 2:30 to 4:20, but now it reflects what you all have on your end, which is the Monday and Wednesday, 2:30 to 4:20, Tuesday, Thursday, Friday, 1:30 to 3:20. The good thing with today is that you will not go over 3:20. I will definitely keep that in mind. We're gonna make sure to get through everything on time. We don't have a whole lot left. And again, we are both Dr. Colhane and I are making the conscious effort to record everything through Panopto. In case you need to refer back to anything, and then all the folks who left after realizing that class wasn't starting at 1:30 today, they can also view the recording via Panopto. So that is that. So before we get started and resume with the rest of hypertension, any questions that anyone wants to clarify from yesterday's review? And if anything comes up, just let me know. A few things that I didn't capture in the recording, but just so that everyone is on the same page, including those who watch the recording. There is case application day next Tuesday, the 26th. That will be essentially, as mentioned before, I'll give you like more of a detailed breakdown probably next Monday, but pretty much you'll have like a 10-question quiz. You'll have an allotted time to complete that quiz, followed by a case activity, which will take up a bulk of the time for the class. It's about an hour. And then after that, we will go through everything together, as in I will make sure that you all have an understanding of the quiz and then also the case. And this will set you up for success for the exam, hopefully. In addition to that, I did mention that I can provide to you some case practice. So because this will be your first case application activity as a whole, I can give you like a case to work through. So I'll post that. It will probably be posted by the end of the day today. And that way you could just like practice on your own time. That will not be graded or looked at or anything. And then also I do study guides. So because I believe in them, you will receive a study guide tied to my material, which will hopefully help as you prepare for the clinical portion of hypertension for the first exam. And you will get study guides from me, by the way, for the rest of the module. So I hope that relieves a little bit of stress and tension. My study guides, if you all recall, are very straightforward. I don't do surprises. I don't like surprises on a personal scale, so that's why I don't give surprises. So that's my philosophy. And not every professor will see it that way, but just so you know, I like study guides. Because I don't want you to like focus on the nitty gritty details as much, just like the big picture. So that's the goal. Okay. Any questions before we jump back in, start covering RAS inhibitors? Okay, great. So we have under the RAS inhibitor class, there's the ACE inhibitors, which you all have already been oriented to a little bit from a science perspective. On the right-hand side, you can see some examples of what ACE inhibitors are. Hopefully you all have like seen them before in some capacity. I mean, top 200. And then also, if you worked in like the practical setting, they are like one of the most common class of drugs. They end in pril, so very easy to identify. So these are one of the most commonly prescribed medications, not only for hypertension, but other cardiovascular related things. And again, we'll go through the rest of them as the module builds. But the benefit that we get out of using ACE inhibitors are, again, from a mortality and morbidity standpoint, they also have, as mentioned, so heart failure after myocardial infarction, coronary artery disease, diabetes, CKD, secondary stroke prevention, all these things, we can get a lot of benefit with using ACE inhibitors. And then, as mentioned briefly yesterday, we got into this discussion, and it's going to be slide 48 that has the detailed explanation, which we'll get to slide 48 right now. We'll just get through this, but they're not as effective in Black patients as monotherapy, but equally effective when combined with calcium channel blockers or diuretics. Now, the main thing is that when we were going over the compelling indication slide, as you saw, if it's an African-American patient who doesn't have any other compelling indications, we opt for a calcium channel blocker or thiazide diuretic. That's preferred because the benefit that we get with those is more than what we would get out of using an ACE inhibitor. So that's just reiterating this, that maybe as adjunct, we could add on an ACE inhibitor or ARB. I'll get to ARBs actually after, but like ACE inhibitors, essentially, we don't use them to start patients off, African-American patients off. And again, if they don't have any compelling indications. That's the key thing. As far as place in therapy, they're first line, used commonly in combination with other antihypertensives. And then as far as safety goes, so the most common side effect that patients have is this dry cough. There is the mechanism. Did Dr. Colhane go over the mechanism? Okay, cool. Yeah. So inhibition of bradykinin breakdown. So that's why that happens. The other things are hyperkalemia, and then increased serum creatinine. These are like, the chances of these side effects occurring go up as you increase the dose. And then there's also a typical and expected rise with the serum creatinine, like up to a 30% rise. This tends to occur if, it can occur in like stable renal function, but in the situation that a patient already has fluctuating creatinine and you add on an ACE inhibitor to their medication regimen, it's going to make it worse, as in it's going to make the acute kidney injury state worse. So that's why we hold off in such patients until we ensure that their renal function is stable. Even if they are a chronic kidney disease patient, and as long as their serum creatinine is like around the same level over a course of time, we can start this safely. Yes. Yeah, that's what, because we were going over the nephroprotective effects of ACE inhibitors. That's what I was trying to connect this to. So yes, ACE inhibitors are protective of the kidneys, but they have this potential to cause this sort of acute response from the kidney biomarkers, which is primarily serum creatinine. So we could see a rise in that, but that doesn't mean that it's damaging the kidney over a period of time. It's actually protecting the kidneys. So that's just something that, again, it's like a clinical consideration that we have to factor in. And then hypotension, which goes again for every medication that we're going to go through because they lower blood pressure. So that's a potential risk. Okay. In this situation that we have angioedema, so this is a rare side effect. This is something that can happen at any time, unfortunately. There was a patient just last week that I saw in my service who'd been on like their lisinopril for like almost 10 years. And then they seemed to develop this angioedema-like reaction. We couldn't identify any other cause. So you're probably like, this is probably what it is. Therefore, they need to be taken off of it and then be given something else for management of their blood pressure. Yes.
So with the renal thing, the ACE inhibitors, will help in protecting the renal, but at the same time cause renal dysfunction. Is that what it is?
No, so renal dysfunction is, I would use the terms carefully. It can cause this acute response, but it doesn't mean that it's damaging the kidneys over a long period of time, because they work to protect the kidneys long term. But it's just that in the acute phase, sometimes they can lead to this like bump in serum creatinine. It does normalize. It's not something that stays permanently elevated, and it doesn't, cause this dehydrated sort of state, which is what we worry about if the serum creatinine rises. But it's more of an acute reaction or acute response, kind of like you poke at something and then it just, reacts or gets inflamed, but then it settles eventually once introduced slowly and gradually. So that's the idea. And it actually, this class should not be discontinued or avoided just because of that, as in we get more benefit from protection of the kidneys than to not have a patient be on them, if that's the only reason. Does that make sense?
Yeah, so the reason I asked is because like top 200, it says the side effects of ACE inhibitors is renal dysfunction. That's what I say. So
okay, yeah, I'll be careful with asking that question then. It's renal dysfunction. That's like a loosely, but I guess the main thing that can happen as we're talking about it is more the acute response, acute renal or acute kidney injury type of response. But yeah. Mm-hmm.
So clinically, when a patient is on this and the patient notices signs of acute kidney failure, what do you do at that point? Do you take the patient off the ACE inhibitor immediately, or you go to take the dose down, even if it's not going to be effective at that point to control the blood pressure?
Yeah, so we look at how much of an increase we're seeing. So as mentioned, if it's a significant increase, like more than 30% or above 1, then we would discontinue. And then once the patient's kidneys stabilize, when their like serum creatinine has been about at the same or at their baseline for, I would say, at least 3 days. And again, I'm speaking on the hospital setting because we check labs every day. At that point, you would introduce at probably a lower dose. The lowest possible dose, by the way, like lisinopril, for example, the lowest dose of that is 2.5 milligrams, which is such a small dose compared to its maximum, which is 40. So sometimes we just use the approach of let's start with that baby dose and then slowly see how the patient does.
But during that time, how do you manage the patient's blood pressure?
Opt for other classes, like use other treatments. We just avoid the RAS inhibitor class.
Okay, you use other classes, and then once the patient is stabilized, you come back to the ACE inhibitor, right?
Yes, especially if they have like compelling indications like diabetes or CKD. So those things are some reasons as to why we would come, like, especially, yeah, like I would see if they have a reason enough to be on it, then usually we like to use them because they do protect the kidneys long term. So, and I say they because I'm also thinking of ARBs. ACE and ARBs, I use the example of like, they're kind of like fraternal twins. They're like the same. The only difference, like literally the only difference is ACE inhibitors cause a cough. ARBs do not cause that cough because the bradykinin mechanism doesn't apply. So that's the only difference. So that's why they're like, you can't be on both at the same time, which is what we talked about. It's like duplicate therapy basically. So that's why. Any other questions? That's a good point. Cool. Okay, so then angioedema, kind of talked about the background, like it can happen literally anytime. So we see like what you see in the image there. There could be swelling of the mouth, tongues, eyelids, and then it could potentially affect your breathing because it's in like the laryngeal region. And then there's an increased risk in African American patients, but still very rare. And then in such cases, it's not considered like a contraindication for use. So like what is meant by that is like you have to define it patient specific wise, like if it got into the way of their breathing and if it was like life threatening, then that's where we would probably try to avoid. If it was more so like some of the other like reactions tied to the angioedema, then some practitioners, I'll speak for what I would do, but like some practitioners may be like, it's fine. We'll weigh the risk and benefit. If the benefit is more, then we'll maybe, again, start low dose and then see how the patient reacts. In my case, like if I know a patient has a history of angioedema or anaphylaxis, to a RAS inhibitor, ACE inhibitor, or ARB, then I would probably just recommend avoiding it altogether. Like don't risk it. We have other options. But some practitioners may get into the whole, like the patient has compelling indications like diabetes or CKD. So like maybe we get more of a benefit with them. So I don't know. Everyone sees it a little different, but personally, I think I would probably be like, guys, like I think we should probably steer on the side of caution. So.
Okay, so angioedema is reversible?
Angioedema, once you discontinue the offending agent, then yes. Mm-hmm. So once you stop this, then ideally, hopefully, if it's due to the RAS inhibiting agent, then it should resolve. And then you would need to like still probably intervene with like your EpiPen and then your like potential antihistamines and things like that to calm the symptoms down. But as far as like that being alleviated, it should not cause like long-term irreversible effects, if that makes sense. Like, yeah. And then the cross-reactivity with ARBs is low, but should still be used with caution. Practitioners kind of see it as there is a risk for cross-reactivity. We don't have enough data. That's the reality. To really say, ARBs are safe, even if you have a history of angioedema to an ACE inhibitor. So that's why everyone just kind of is like, let's just think of it as if a patient is allergic or has the side effect to an ACE inhibitor, then you should probably avoid the ARB as well. And I think that's fair because you'd rather be safe than sorry, especially if it starts to like obstruct a patient's airways and, they can't breathe and then, terrible things happen. So that's why probably better to be safe with that. Okay, and then contraindications. So history of angioedema, idiopathic or hereditary angioedema, hyperkalemia, pregnancy, and then also bilateral renal artery stenosis are all things. As for pregnancy, so we'll get to the details of like what we do in pregnancy at the end. It comes up later. So ACE inhibitors, they should be discontinued when the patient becomes pregnant. And then drug-drug interactions, you can see there pretty much like potassium-sparing diuretics, aldosterone antagonists. We just have to watch out for our potassium levels. And then NSAIDs. So NSAIDs are considered problematic as far as like worsening blood pressure control. So that's why it's recommended to like try and avoid them. If a patient does need an analgesic, we try to get them on Tylenol. If their pain is more severe, then we could explore like low dose opioids. But NSAIDs are just not considered the best because there's an increased risk of renal dysfunction and then also like causing worsening of blood pressure control. So that's that. And then, yeah, just as far as how the dosing goes, it's once a day. And then as far as dosing for like just in general, these agents. So historically, like you probably haven't seen a whole lot of dosing questions in PT. I will say like for this module, it does matter to know at least like the most commonly prescribed drugs and what their dosing range is. For my study guide, I'll indicate to you like which drugs you need to know it for. Like for lisinopril, I think it's very helpful if you know like the lowest dose that you can start off technically is 2.5, and then you can go all the way up to 40. So yeah, that's one like ACE inhibitor that I can think of that you like if in clinical practice you see it, you should recognize, okay, this is the dosing range. And then there's others, but I think lisinopril is like a definite, like you need to know that. So that's that. And then counseling points. So if a dry cough occurs, notify your provider, things like that. And then signs of angioedema, avoid potassium supplementation and potassium substitutes. And then ACE inhibitors have evidence for use in comorbid disease states. We kind of talked about that already. Start at lower doses that are volume depleted or on diuretics, and they're first line. So same stuff that we already kind of covered. ARBs. So very, very similar to ACE inhibitors. I won't read every single thing that's on the slides because there's a lot of overlap. I'll just highlight to you like how you can identify them. So they end in sartan. That's the way to, identify if, there's an ARB that a patient is on. The more common ones that I tend to see are losartan, valsartan, candesartan, and then sometimes I see olmesartan. But yeah, those are more of the common ones that we tend to see. And then it's this slide 48 that I was referring to just with why ACE inhibitors and ARBs are not first line. So they're less effective at blood pressure lowering. And just to read that to you. So African-American patients, they have less reduction in blood pressure when started on ACE inhibitor and ARB monotherapy compared with thiazides or calcium channel blockers. And that's because of a high prevalence of low renin hypertension, making the renin-angiotensin-aldosterone system, RAS, less of a driving factor. And then there's not as much protection against stroke and cardiovascular events. So they had like higher rates of stroke, heart failure, and combined cardiovascular disease events compared to those on thiazides. Again, those who had only hypertension did not have any other compelling indications. And so thiazides and calcium channel blockers had better outcomes. And then higher risk of side effects. So as mentioned, like angioedema, it's still rare, like the frequency isn't all that high, but it does occur more frequently in the African-American patient population compared with other groups. And so that just reduces kind of their appeal if a patient only has hypertension and not any other reason for being on RAS inhibitor. So that is that. Okay. So safety-wise, same old. Dry cough is not a side effect. That's really the key thing I want to highlight to you. Everything else you can take from the ACE inhibitor review. Any questions? Okay. Yes.
So it's first line except for Black patients without the compelling indication. And the data that you were presenting was because that's the reason why.
Yeah. So we opt for calcium channel blockers or thiazide diuretics in African American patients who don't have a compelling indication. Yep. And that's just going back to the compelling indication slide that we went over yesterday, just to address that further. And the comments, you should be able to see them on your end too. They're on slide 48 in case you want to go back to that. I can post them on Canvas too, just so that everyone kind of sees the background of it. But okay, and then clinical considerations, same old as ACE inhibitors. This is just like an overview of electrolyte abnormalities that can result with using the different classes. So thiazides, potassium-sparing diuretics, aldosterone antagonists, and then ACE inhibitors and ARBs. Just to keep your electrolytes straight. Thiazides, as we reviewed yesterday, the only thing that they increase is calcium. Potassium, that only affects potassium. It increases it. So that's that. Aldosterone antagonists cause an increase in potassium only. And then ACE inhibitors cause an increase in potassium as well. So just to help keep the electrolyte pattern straight. Yes. Question?
So I would just say when we say potassium sparing, we are not considering that aldosterone antagonist has been in the same class.
It's not it's a little different because aldosterone antagonists, I think it's a misnomer when we try to say they're potassium sparing. Yes, they cause the hyperkalemia outcome, but as far as mechanism goes, I would group them as kind of like their own class. Potassium sparing in my head is what we saw before, the amiloride, the triamterene, the weaker antihypertensives that usually have to be combined with thiazides to regulate potassium levels and maybe even potentiate the blood pressure control.
So we classify spironolactone as potassium sparing?
I wouldn't call it that because it's not potassium sparing diuretic. And again, the term diuretic implies that you're taking fluid off and encouraging urination kind of with that class of medications. Aldosterone antagonists don't really have that effect. We're not concerned with that. I feel like every time I hear the term diuretic, that's where my mind goes to. The nocturia concern is that we have that with thiazide diuretics. We have that concern with loop diuretics, which we'll get to later. Potassium sparing can also have that urination sort of effect. Whereas spironolactone as an aldosterone antagonist, it used to be called a potassium-sparing diuretic, but it's kind of its own thing as far as grouping goes, I think. Yeah. Good question. Any other points of clarification? We're about to get into our last first class agents. So our calcium channel blockers are our last first line. And then we have beta blockers, which are which I'll go through, but they are not considered first line. So it's just the calcium channel blockers that are considered of our first line options. So of the calcium channel blockers, as mentioned yesterday, we use the dihydropyridine class of calcium channel blockers for blood pressure control. We don't really opt for the non-dihydropyridine agents unless the patient has some sort of arrhythmia for which they need their heart rate to be controlled. So we'll go through more of that in arrhythmias when we cover it later in the module. But for now, the main ones that we use are amlodipine and then nifedipine extended release. Those are the common ones. You can see other agents here, but I see amlodipine and nifedipine the most for reference. And then as far as safety goes, so the main side effects that I've seen is actually peripheral edema. So just fluid buildup in the extremities, arms or legs. And it could potentially be alleviated when combined with an ACE inhibitor or ARB. We also can see some sort of, flushing and headache sometimes. But the key counseling that I always provide is the edema. So just looking out for fluid retention. And then there's, just potential interactions that can happen with with this class. But they're generally well tolerated. Like calcium channel blockers are nice because you don't have to account for renal dysfunction or like, concerns along the lines of what we saw with RAS inhibitors. But yeah, question.
Yeah, for the peripheral edema, why are we combining it with ARB? Why not combining it with the thiazide?
You can. It's just that like in terms of there's like data to suggest that when you combine with the RAS inhibitor, then we see better, just a better result as far as like edema as a side effect is concerned. But as far as the thiazide combination, yeah, you can do that. I mean, that theoretically makes sense and there's no reason why we can't. So yeah, that's a fair point.
So if you give us a quiz for peripheral edema management in this case, should we pick a diuretic or we should pick an ACI?
That's a bad question. I wouldn't do that.
Because we're coming straight from the slide.
It's coming straight from the side, but that's a bad question.
Okay.
Your key takeaway should be that calcium channel blockers, dihydropyridine calcium channel blockers can cause peripheral edema. That's like a side effect that you should know. When it gets into the nitty gritty, that is a nitty gritty example because like, yes, I've seen that, data suggests you may not see as much of it with ACE inhibitor or ARB, but you can see that same sort of benefit come about with using a thiazide with it, right? That's like not a good question. So I wouldn't do that to you. And then another thing is reflex tachycardia. So what that means is basically administration of it could cause like a jump in heart rate. It usually normalizes, but that is something that sometimes can be a problem, especially if like patients, they have underlying some sort of arrhythmia, they have like a heart rate control issue, but don't run into it as frequently. The edema is definitely like a common thing though. Any other questions? Okay. And then as far as just like drug-drug interactions, we'll just like review kind of what happens when we're using an inhibitor in combination with an inducer, and then with the CYP3A4 inducer and then a CYP3A4 inhibitor. This is just like a key clinical test as far as like any medications go, not necessarily hypertension, but just to ensure we all understand. If we're using a like CYP3A4 substrate medication with an inducer of the same enzyme, what is something that can potentially occur?
It will decrease the efficacy of the drug.
Yes, exactly. Yep.
If it's not a prodrug.
Yes, exactly. We don't see as much because inducers essentially increase the metabolism. So like increase the basically like potentiate the excretion or elimination of that drug. So what that means is we're not going to have enough of that blood pressure medication in the system, and our blood pressure is not going to be controlled. So we're going to see a higher blood pressure reading. Does anyone remember any CYP3A4 inducer? Like an example? Rifampin, absolutely. St. John's wort, that's a good one. So yeah, like these are some things to kind of keep track of. If you see them, what interactions can potentially happen. There's phenytoin. Yeah, that's one of them. I'm like kind of bad at it. So yeah, I myself need to review a little bit of but there's fewer inducers than inhibitors. So like if you remember the inducers, then you can identify them, like say, and they come up on boards. So like identifying which ones are the inducers, that way you can eliminate those and be like, okay, the rest are all inhibitors. That was my strategy at least. So, and then within the use of a CYP3A4 inhibitor, we see the opposite effect, which, makes sense. So we see toxicity that can happen, meaning too much of the blood pressure medication. So we can see like low blood pressure and then just side effects linked to that particular class. And then we worry about these things with like calcium channel blocker use, particularly. That's why like this slide is here. That's the intention. These are also given once a day. So like, as you notice, the administration is pretty much once a day, but it can be up to twice a day. For some of them, like our thiazide diuretics can be up to twice a day. ACE inhibitors and ARBs are like almost always once a day. And then calcium channel blockers, usually just once a day too. And then they're pretty accessible as well. As I mentioned, nifedipine, extended release, and amlodipine, those are the more common calcium channel blockers that I see in practice. As far as nifedipine immediate release goes, that we don't use because it can cause adverse effects like adverse cardiovascular, which is weird. I don't understand. Like the immediate release, it's basically just not a good formulation. So that's why we go with extended release. Okay. And then as far as counseling goes, so just the edema monitoring, which could be like looking out for patients' weight, making sure that they're keeping track of that. And then, as mentioned before, immediate release. So that and nicardipine, they've been associated with adverse cardiovascular events and should not be used to treat hypertension. Calcium channel blockers are generally well tolerated and may be added on to other antihypertensive medications. And then amlodipine's been found to be safe for treatment of hypertension and heart failure patients. We'll talk about heart failure later, but amlodipine is like one of the few that it's not part of heart failure treatment, but it can be used if needed, and it won't cause problems. And then these, I'm just going to skip past, like I'll just go over them as far as like they're there, but again, we reserve them for underlying arrhythmias or like, heart rate control issues. So don't really use them first line, and you'll see them later in the module. So I'm not going to spend too much time on them. Like they're there. Examples are diltiazem and verapamil, but again, not really, you don't have to worry about them at this point, just for hypertension. Okay, and then beta blockers. So they're not as effective as other agents in preventing morbidity, mortality when used as monotherapy. They're not first line. Again, our first line we already went through: thiazides, RAS inhibitors, which were the ACE and ARB, and then calcium channel blockers. That's it. These are considered when patient is basically at this resistant point where like they're on all three first line medications. We could consider the addition of a beta blocker therapy. As far as which ones we consider, so as you can see on the right-hand side, the non-selective section, that being nadolol, propranolol, timolol, and then carvedilol, labetalol, those are all, like everything from the non-selective all the way down are going to have blood pressure effects. Everything above that, where it says cardioselective, so all the way up until from atenolol to nebivolol, those are selective, meaning they're primarily going to work on the heart, and they're only going to primarily have heart rate control effects, not so much blood pressure control effects. So we'll use those mainly for like heart rate management, not so much blood pressure management. And then of the non-selective agents, the ones that are seen clinically in practice, the ones that I see are mainly carvedilol and labetalol. I don't really see any of those. Propranolol, it has some use in liver cirrhosis, like complications tied to that. But as far as blood pressure control goes, labetalol and carvedilol are the go-to. You will see that labetalol is our agent for pregnancy. Like when patient is pregnant and we're trying to get their blood pressure under control, we use labetalol for them. So that is that. But yeah, not first line, not first line, not first line.
Please clarify what you mean. You say we use it for heart rate regulation, but not for hypertension. Because I was thinking when you regulate the heart rate, there should be an effect in terms of reduction of blood pressure.
It's like minimal. You're not going to see a significant effect because if you think about it, the beta-1 receptors, which is primarily where the beta-selective or cardioselective medications will act, beta-1 receptors are located on the heart. And we are trying to target more than just the beta receptors that are on the heart. We're trying to target the ones on the vasculature So like in the vessels, to make sure that the vasoconstriction opens up to become more dilatory. And that's why the non-selective, which you can see like alpha and beta blockers, that's the effect that we're trying to achieve. Because we want, dilation to happen not just in the heart, but everywhere, So that's the idea. We can see an effect, but it's so mild. Like if, say, metoprolol is one of the more common cardioselective agents, it's sometimes like a dose-dependent thing. So like the higher up we go in the dose, we can see a blood pressure reduction, but it's not something to bet on. We can get a better effect with that with the non-selective agent. Okay, side effects of beta blockers kind of make sense. Bradycardia, so reduction in the heart rate. And then we try to hold if the heart rate is below 50. We can sometimes see exercise intolerance and fatigue, constriction of the bronchioles, mainly with the non-selective agents. So in the situation that we have a non-selective agent, like you probably remember, so beta 1 receptors are on the heart, as I mentioned. Beta 2 receptors are on the lungs. The way to remember that is there's 2 lungs, so the beta 2 are on the lungs, and then 1 for beta 1 because there's 1 heart. So because of targeting the beta 2 receptors, sometimes the bronchioles can constrict because of the blockade, if that makes sense. And then if that patient is on, say, beta agonist like albuterol or something to open up the airways, it like counteracts the effect. So that will be potentially a question. Just be mindful of that. So like if a patient has underlying asthma or COPD and we give them a non-selective beta blocker for their blood pressure control, then that's probably going to cause bronchoconstriction. So we don't want that to happen. That's not a good thing, because then their airways and their bronchioles will close up. So in that situation, we either try to go for something selective or we look for a different agent to try to manage their blood pressure. Does that make sense to everyone? Okie dokes. And then other things here, you can see potential for, or contraindications for use are AV block, decompensated heart failure, bradycardia. We talked about the asthma and COPD. So like if a patient has any of those, using a non-selective agent can be a problem. And then drug-drug interactions there for your reference. Yeah, I'm not going to harp on these too much. I think the key thing that I want for you all to take away is, again, using a non-selective beta blocker in asthma or COPD is not recommended. And then, and then sometimes in clinical practice, I do see patient, if they have underlying cocaine use history, then using beta blockers can be a problem. If we have an unopposed alpha blockade, or basically there's stimulation of that due to cocaine use. And so when we use an alpha blocker, again, a non-selective beta blocker agent, that could lead to worsening vasoconstriction for them. So we have to err on the side of caution of using a non-selective beta blocker in those patients as well. Yeah, and again, if there's anything else that I think of, you'll see it on the guide. If you need to know anything else about beta blockers.
Just one question.
Mm-hmm.
Back to our CCBs. Have they also run out of
Sorry, say that again. Calcium channel blockers?
Yes. Can we say they are run out of
No, there's no data, strong enough data to suggest that. No. Yeah. They're just their primary therapeutic outcome has to do with the blood pressure management, if anything. And then the non-dihydropyridine agents, those work to do pretty well at controlling heart rate. But as far as other effects, we don't really have much data to suggest a benefit elsewise.
So if we have a blood patient who doesn't have other comorbidities, we cannot use an ACI beta form, and we want to protect the kidney for that patient, what do we do?
Do they have underlying CKD? Because if they have underlying CKD, then we would be worried about protecting their kidneys. and then that's where an ACE or an ARB would be fine. But like there's no thing, not necessarily like a thing where like you're trying to preemptively protect their kidneys if they don't have underlying CKD, you know? Because the addition of it, I would think like we would add it and then it would hopefully help to prevent the progression of the CKD. But if you're describing someone who the only thing that they have going on, they're African American, but they have no other comorbidities. They don't have diabetes, they don't have CKD, they're otherwise like healthy and normal. Then we could just manage the blood pressure. And then that in a way is preventative of developing CKD and the other vascular complications that we worry about, like cardiovascular disease complications. So that's the approach. Any other questions? We got like 8 minutes. My hope is that we can just fly through the rest, hopefully. Okay, so then beta blockers, as far as like how often they're given, once or twice, depending on which one it is. And then we never want to stop a beta blocker abruptly. It can cause severe rebound hypertension. They should be slowly tapered off if that is necessary. And then we'll get to the heart failure recommended beta blockers, but the ones you'll see are bisoprolol, carvedilol, and metoprolol succinate. Those are the only ones that we do in heart failure. Again, not a concern right now, but it'll come up later. Okay, any questions about any classes that we've covered so far? So again, to reiterate, like from my understanding, Dr. Culhane didn't review the mechanism for beta blockers yet, but not to worry. This class will come up and become relevant with other conditions that are coming up later in the module. Beta blockers are not first line for hypertension management. We do them more as like add-on. So even if you're not totally familiar with the science behind them, like from my standpoint, as I explained, selective versus non-selective, like that's about as deep as it's gonna get. And then if there's anything else, then I'll make sure to keep you all informed. Okay, monitoring. So this is just a general thing, like as far as blood pressure monitoring goes, we do it at baseline, then every 2 to 4 weeks. And then we don't monitor as frequently once we achieve our blood pressure goal. And then the signs and symptoms of target organ damage, you can see just kind of what the potentials of that could be. We kind of talked about a little bit of them before, but just so you know, potential for stroke, acute myocardial infarction, left ventricular failure, aka heart failure, renal failure, and then eye changes like retinal changes. And then toxicity wise, this just gives a summary of kind of how we're monitoring for each therapeutic class. And then just, how frequent we would monitor each. So this is more so just like as a reference point for how we would keep track of everything. As for, so up until this point, we've covered everything for like chronic hypertension management. Any questions about that? Okay, so we'll just shift gears a little bit and go through crisis management. So this is what this is a situation in which a patient would come into the hospital and we would need to acutely manage their blood pressure and or other symptoms that they may be experiencing. So this is defined as a reading of 180 over 120. There is an or, so like either a systolic of 180 or higher, or a diastolic of 120 or higher. I think this was in the category slide. So that's just to, something to keep in mind. And then target organ damage. So these are some examples of what is seen in the situation that there's target organ damage. We kind of reviewed these. This was on like another slide as well, but that's what that means. In the situation that we have no target organ damage, that is called severe hypertension. In the previous guidelines, it used to be called hypertensive urgency, but now it's just called severe hypertension for the new guidelines. So we don't have target organ damage at this point. It's just high blood pressure. That's all. So we're trying to get it down to less than 160 over 100 over hours to days. We're not trying to do it quickly. So because the target organ damage isn't present, it's not something that we have to immediately try to like fix, if that makes sense. And this often regulates by itself. As you can see, blood pressure will often decrease on its own by allowing the patient to sit quietly. Yes, question.
So you don't do it you don't do it quickly because like since the body is accustomed to that high pressure, you will lower perfusion to organs.
Exactly. It affects perfusion to the organs. And if you do it too quickly, then we could have the patient experience like precipitation. It could cause things to go haywire, which is not the goal. And again, this is if we don't see any evidence of target organ damage. Yep. So it's like not, I mean, it's concerning, obviously, like that the high of a blood pressure is a big concern, but it's not life threatening. This is like, it's a problem, but you're not like the patient isn't like at risk for dying right then and there, if that makes sense. So that's why the approach is a little bit like slow and steady. You don't have to be as extreme. And then oftentimes we just give like oral blood pressure medications. Usually this happens if a patient like isn't compliant to their medications. So like if they're just, forgot to take them for a couple of days and, their blood pressure just gets out of control. But otherwise, nothing else is going on. Just get them back on their routine and then identify reasons for non-adherence with them. So that's really it. Very, very straightforward as far as management goes. But as you can see, like the goal is less than 160 over 100 as far as like what our numeric goal would be. Hypertensive urgency, this is a little bit different. So this is where we do see the target organ damage. We have to do immediate reduction so that we prevent or limit the progression of further target organ damage. The goal is to reduce the systolic blood pressure by no more than 25% over the first hour. And then if stable to 160 over 100 within the next 2 to 6 hours. So as opposed to here, urgency or severe hypertension, you see like over hours to days. This is like time is money. So 2 to 6 hours is our window to get it less than 160 over 100. And then we cautiously can lower it to normal over the next 24 to 48 hours. Doing an abrupt drop in blood pressure, that could also be a problem. It could lead to ischemia, like loss of blood supply. So we don't want that to happen either. But still, the time aspect is a little bit more defined for emergency management, hypertensive emergency management. The IV medications that we use, which in this case, we would resort to IV medication use. That would be sodium nitroprusside. At my hospital, we use nitroglycerin. We also use nicardipine, and we also use labetalol. So those are some of the common ones that we tend to use. So key differences, as you can see, like time is more clearly defined, and then we use IV antihypertensives, whereas in severe hypertension, we can rely on oral only, and it will get the job done. Okay, any questions about our crises? Yes.
Hypertensive crisis, there are two types.
Yeah.
You have the severe,
Mm-hmm.
the other one?
Is emergency.
Emergency. Okay, now, please clarify again this issue of rapid drop. Within 2 hours, 2 to 6 hours, we want to bring the blood pressure down to below 160, and we say this can lead to precipitation. So how do you deal with that problem?
So if we rapidly reduce in severe hypertension, then there's a concern for possibility of renal failure, MI, or stroke, cardiovascular outcomes that can result as a result of trying to do it too quickly in severe hypertension. We don't have target organ damage at this point. Whereas in emergency, we do, and we need to ensure that the blood pressure is under control to prevent progression to target organ damage, further target organ damage. So the approach is more time-based in this subset and not time-based in this subset. It's a little bit
What
more.
I'm saying is, if we do it in 2 hours, we won't get the same precipitation problem.
In which subset? Can you clarify, like, which subset are you referring to? This subset or?
You already have a target organ damage.
Okay, so hypertensive emergency.
Yes,
Mhm.
so with the emergency, if we reduce it quickly, are we not exposing the patient to another risk of maybe other organs getting damaged?
No, in that case, we don't have to worry about, like, the 2 to 6 hour window is what is considered beneficial to get the blood pressure less than 160/100. Whereas in the situation of no target organ damage, that is not the case. It's more of like that number. Yes, we have at least 180 or higher, or diastolic of 120 or higher, but we aren't seeing any other systemic abnormalities. But in the emergency situation, we are. And not controlling the blood pressure in the situation of that emergency where, like, you know, your other organ systems are going haywire. We want to ensure that the blood pressure doesn't affect other organs too, if that makes sense. So and this is all driven by data, as in this is like evidence-based, you know, seeing that, okay, this is the window that we have to treat this according to this. Does that make sense? Okay. And then lastly, we have of our special population. So there's the pregnancy category of patients. We have our chronic hypertension patients, gestational, and then there's also preeclampsia, which is more of that concerning outcome that can happen. As for our goals, so or like the subsets that we can see in such patients. So severe hypertension, our goal, like our threshold is a little bit more stringent. So if we see a blood pressure of 160 or higher or 110 or higher, and so we want to treat it right away to less than 160 over less than 110. And then you can see like the other stuff. The preferred medications for pregnancy management are labetalol and nifedipine. Some alternatives would be methyldopa, and then we could continue thiazides if the patient's already taking them, but the evidence is a little unclear. So we're not really sure, but we have hard no's for ACE inhibitors or ARBs or spironolactone. Those are like a no-no. Pregnancy category X can cause fetal harm, but then the others, those are deemed to be safe. So
in this case, we are treating within 30 to 60 minutes.
Mm-hmm, yeah, because you're pregnant, so you want to make sure you don't harm.
But is the goal to bring the blood pressure below that in 30 minutes?
Mm-hmm, mm-hmm.
And then we're not using the medications here, they seem to be
Labetalol or nifedipine. Mm-hmm.
Seem to be orals, they are not IVs.
Mm-hmm, mm-hmm. Because the ones that are studied to be safe in pregnancy are particularly, so you can use IV labetalol. I mean, yeah, that's a possibility. It does come as IV.
Okay, because I was just thinking that how fast for you to get it 30 minutes.
Yeah.
IV.
Yep. Mm-hmm. So that's a possibility. Yeah, nifedipine is oral, but once the patient's stabilized, they can get the oral form. But labetalol can be done IV. Mm-hmm. Okay, and then the elderly. So this, let me see if there's any key takeaways. I mean, we kind of talked about this already, this concept yesterday as it tied to like our epidemiology review. The older you get, the more susceptible you are with increasing your blood pressure, all that jazz. So as far as what we do, we just weigh the risk and benefit of doing certain things over others. You can review, let me know if you have any questions. And then lastly, finally, this is important. If we have a patient who's on maximum target doses of 3 drugs that are first line, and they're still not well controlled on their blood pressure, then that's considered resistant hypertension. So then firstly, confirm true resistance, optimize the triple therapy if there is room to do so. And then add a mineralocorticoid receptor antagonist, aka spironolactone, if we can, as long as there's no contraindications. And then the others that we could add are beta blocker. There's clonidine. We didn't really talk about that. I don't like it as an antihypertensive, so you do not need to worry about it. And then in the hospital, you may even see hydralazine. and then secondary causes, and then, referral. So that is that. Any questions about our review today? Went a little bit over, but at least we're done. And Monday there won't be any class, so that's nice. But yeah, if you all think of anything, just let me know. And then again, I'll send you a case, like a practice case to do. And we'll, I guess plan for Monday, just to be clear. So I guess I'm trying to think, like, do you guys want me to come here, or like I could hang out in my office, and then if anyone has any questions, you want to swing by? I don't know. Okay, sounds good. Like, and then I'll provide like a guide, and then if you have questions tied to the guide, we can address them like on Tuesday too. Yeah, I'll let you know. I'll email y'all. Thank you. Thank you.
That is going to be like we need to focus.
Yes, for my portion. Yeah. Mhm.
Okay.